Yesterday, I spoke a little bit about what the surgical options are, and Dr. Shishbor asked me to talk a little bit today about how to decide between open or endo in a surgical practice. So these are my disclosures, which have sadly not changed since yesterday. So importantly, as was discussed earlier, a good pre-procedural evaluation, regardless of which procedure you're going to do. So a general medical evaluation, we include the hospitalist with all our patients. Is the patient fit for surgery if an endovascular approach is not available? Assessment of anatomy. All our patients get a very high-quality duplex ultrasound along with ABIs and sometimes toe pressures. Many patients have CTA in anticipation of an endovascular procedure or MRA. If a patient has chronic renal insufficiency, we'll sometimes go right to a catheter-based arteriogram because we can limit the contrast load. And we always try and do a vein mapping before the patient goes to the lab. So additionally, in patients with really complex disease, I've been burned a few times by the CTA in that a tibial vessel that I thought was a good target was not. And so we'll take the patient to the lab, do an arteriogram. We know whether they're fit for surgery. We know whether they have an saphenous vein. And if it's an easy endovascular procedure, we'll go ahead with that. If not, and they're a good surgical candidate, we'll at least know what the target is and can proceed accordingly. And again, a multidisciplinary approach, as has been described. Actually, our vascular center was begun by our late great colleague Alan Hirsch, who really brought the team together in all the disciplines. So our first option is best CLI. Although I will tell you, it has been very challenging to recruit. My colleague, partner Jason Alexander is our local PI, and he was lamenting to me the other day that we had a patient enrolled to be randomized. The patient went home, talked to some friends who said, "Why would you want surgery when you can have a stent?" And she backed out of the trial. So it's been incredibly challenging. I think we're up to 7 or 8, but based on our volume, we should be 3 times that. And then we do have an endo-first strategy in our vascular surgery team. So indications for surgical therapy for aortoiliac disease, that which is not amenable to endo, or young fit patients with very complex disease. The common femoral artery, endarterectomy first, and we have an increasing number of hybrid procedures. These are with endart and iliac stent or endart and distal intervention. And for infrainguinal disease, failure of endovascular therapy either initially or with recurrence after successful initial endovascular therapy. And of course I have to show a couple of pretty pictures to show you that this is a typical patient of ours with an ostial anterior tibial artery lesion and occlusion of the DP. The perineal and PT don't actually communicate with the foot. So an intervention of the DP, and then following a unsatisfactory angioplasty of the proximal AT, a drug-eluting stent. So all of my 7 surgical partners are well-versed in complex endovascular interventions, and so we're very comfortable with this. And sometimes we ask for the help of IR for those of us who are not as comfortable with these very distal interventions, but this is vascular surgery practice today. And as you can see in this chart, in patients with diabetic feet who underwent revascularization, that the volume of endo is going way up and the volume of open surgery is going down, as one might expect. In our vascular center, this is data back to 2014. The volume is up about 15% from then, but about 250 endovascular infrainguinal interventions and about 80 lower extremity bypasses. And so we're now more of almost 4 to 1 in favor of endovascular. And that's reflected in the trainees. So a case log of one of our recent fellowship graduates, he did a little over 800 endovascular procedures and about 200 open cases in the course of 2 years. So most surgeons are well versed, at least the ones coming out today, in these complex endovascular interventions. So I want to bring attention, though, to this idea of one is better than the other, because I actually don't think it serves us as a profession well. It doesn't serve audiences who are listening to us. It doesn't serve our patients well. So here's a paper from one of my favorite journals, Vascular Medicine, on BK endo versus open, and an accompanying editorial which states that PVI is better than tibial bypass for CLI. So while that may be the case, this paper didn't prove it, and I'm going to show you why. So 2,500 patients, these are the outcome measures. The majority had peripheral vascular intervention. When you look at, there was no difference in major amputation or mortality, and superior primary patency of peripheral vascular intervention. So let's look at the details. So in the PVI group, 44% had angioplasty of a popliteal lesion, while 10% had a target in the BK pop in the surgical group. 38% of the bypass patients had a target on the foot, the DP or the lateral plantar, where there were no pedal interventions. So these are different groups of patients. The details, the median number of vessels treated in the PVI group was 1. The majority had an angioplasty alone, so these weren't complex lesions. The majority of bypasses with autogenous vein, but was it single segment? Was it splice vein? Was it cephalic vein? And it's likely that many of the bypass patients weren't endo candidates or didn't have an endo solution at the time. So I think that we should actually stop this contrived debate of what's best and say that for each individual patient, there may be a best option. And I think Best CLI is going to help us identify that. So this is a fantastic paper that has been electronically published in Annals. It'll probably come out in the November issue. So it's a Markov model, which is, I'm not a statistical expert, but it's a probability model that allows evaluation of rapidly and randomly changing systems, like a patient. And so these authors from Mass General actually took an imaginary patient, an older patient with congestive heart failure and diabetes with a bad foot. And they looked at amputation, bypass, endovascular, or medical therapy. And based on the literature, they said this is the probability of perioperative mortality, 10% for an amputation, about 6% for a bypass, and about half that for endo. They then looked at the probability of vascular occlusion and said that for a bypass at 1 month, about 7% will fail. And they looked at each month after that, and when they got to 36 months, it was about 0.5% per month. And the same for endo. So at 1 month, about a 22% failure rate. And they then used this model to say, what would that imaginary patient have in terms of quality-adjusted life months? What they found was that medical therapy was the worst, followed by amputation, but the bypass and endo, at least based on this model, were about the same. And that actually reflects some of the literature that was discussed in yesterday afternoon's session. So this should be more about targeting individual patients and what therapy is best than one better than another. So we looked at some cost regarding CLI in our institution. 217 patients treated over 2 years with these procedures. And we looked at their index hospitalization and all inpatient costs for a year. We found that endo was actually the cheapest out to a year, that supply cost, not surprisingly, was highest for endo, comparing endo and open, but that the hybrid procedures were kind of additive of both. That length of stay drove the cost of the open procedures, which is the middle bar. That was statistically significant. And most importantly, Kenny talked a little bit about variability in practice. Look at the variability in cost. So we had one doc who used on average $2,000 worth of gadgets for a hybrid procedure, combined open and endo, and another who used $7,000. So there should be a way for us to manage this locally. The cost of CLI at a year, when we looked at all those inpatient costs, debridements, reinterventions, et cetera, for only 217 patients was almost $8 million. Michael Jaff talked yesterday about the enormous cost of readmission for patients with CLI. This is incredible. Imagine if you could go to your hospital administrator and say, if we were able to standardize this, I could save you 10%. It's almost $1 million a year on only 200 patients. What we also found was that at 24 months, open actually became more cost-effective because of fewer repeat hospitalizations and fewer reinterventions. So a good fem-tip bypass with a good vein is a durable bypass with about an 80% 5-year patency. So in summary, open surgical repair and endovascular therapy are complementary in the care of patients with CLI. That's, for me, the take-home message. Our approach is endo first, and I described that earlier. The cost of caring for these patients is substantial, and it's important that locally we try and reduce variability in care and in cost of care. Endo is more cost-effective based on our data at 1 year, but at 2 years, open surgical procedures actually become more cost-effective and durable. Thank you for your attention.